and thank you for joining us for the first ever Health Chats. This is a new series brought to you by the WSU College of Pharmacy and Pharmaceutical Sciences. Our college is excited and inspired by everything that is related to pharmacy and pharmaceutical sciences, and we want to share our knowledge and latest breakthroughs with the rest of the community. Now, without further ado, today we have two amazing professors who are here to speak with us about diabetes, the important role that pharmacists can play in improving outcomes, national trends, what causes the chronic condition, and strategies for diabetes prevention. Dr. Josh Neumiller is a professor at the college who specializes in diabetes. He teaches student pharmacists about caring for individuals living with diabetes and is an author of several publications on managing diabetes. When he is not teaching, Dr. Neumiller works with the American Diabetes Association to raise awareness and educate the public on diabetes care and prevention. Currently, he is part of a panel of experts educating healthcare providers about the impact of COVID-19 on individuals living with diabetes. Dr. Newsome is also a professor at the college who specializes in diabetes and transgender care. Outside of teaching, Dr. Newsome works at the Mann Grandstaff VA Medical Center here in Spokane, where she consults with patients on managing their diabetes through lifestyle changes and medication. She and Dr. Neumiller teach an advanced diabetes management course together, an elective for student pharmacists interested in specializing in diabetes care. Before I begin, I want to remind our audience that you can type any questions you have for our guests into the YouTube chat. We look forward to hearing your comments and questions. Also, if you have suggested topics for future health chats, let us know in the chat. So the first question goes to Dr. Neumiller. Can you explain what diabetes is? We often hear type 1 and type 2 diabetes and gestational diabetes. Can you explain the differences and what causes diabetes?
Sure. And first, I want to thank you for the invitation. This is a topic that Dr. Newsome and I are very passionate about, so it's great to be able to talk about that today. And so I think that's a great way to start off the discussion, is to talk a little bit about different types of diabetes and definitions, because there is actually some confusion out there between different types of diabetes. And sometimes when I'm working with people with diabetes, they'll even tell me they have one type when in fact they probably have the other. And so in terms of scope, we know that in the United States, we have over 34 million people living with diabetes. So it's certainly a condition we encounter very frequently in the community, in the hospital, wherever pharmacists may be practicing. Of those 34 million people with diabetes, somewhere in the range of 90 to 95% of them have type 2 diabetes, and most of the remainder have type 1 diabetes. So I'll start with type 2 diabetes. It is thought that really type 2 diabetes is largely driven by insulin resistance. So insulin is an important hormone that's produced and secreted by our pancreas that helps us use glucose or sugar for energy. So people with type 2 diabetes, this insulin resistance that they develop doesn't allow their muscle and other tissues to use that insulin as effectively. So over time, what we see in these folks is that their blood sugar will start to creep up or increase over time. And this can take many, many years. So this can be a bit of an insidious disease. And over time, their pancreas, that insulin that it produces, in the short term, it can compensate for that insulin resistance by producing more insulin, but eventually those beta cells, which are the insulin producing cells in the pancreas, have to work too hard and they start to wear out, and we see less insulin production in those people with type 2 diabetes. So eventually the insulin production isn't able to compensate for that resistance, and we see elevated blood glucose. Now, people with type 2 diabetes, there are a whole host of different medications we can use in those people to treat their hyperglycemia or elevated blood sugar. And often we do see people with type 2 diabetes being on 2, 3, sometimes even more medications to manage their blood sugar. In terms of type 2 diabetes, we know there is a genetic component to it. We know that people who have type 2 diabetes in their family, they are more susceptible, but also type 2 diabetes has a huge lifestyle and environmental component as well. So we know that insulin resistance that I talked about is very tightly linked with overweight and obesity. So certainly in the United States, where we have a lot of fast food, maybe people are less active and there's more sedentary lifestyles, that certainly does drive this insulin resistance, weight gain, and development of type 2 diabetes. So again, it's this interplay between family risk and lifestyle type issues. And then the other type, sorry.
Sorry. Can I ask for our viewers who might not know, what does insulin resistance mean?
Yeah, so insulin resistance, again, so insulin is needed within our tissues like our muscle. Insulin is what allows the muscle to actually use the glucose that we take in from our diet to use it as energy. So when people have insulin resistance, insulin receptors in those tissues are just less able to respond to insulin. So again, that's where the pancreas has to work really hard to make more insulin to counterbalance that insulin resistance that develops. And again, that insulin resistance very tightly linked with overweight and obesity, which tends to be a driver of the type 2 diabetes pandemic. So thanks for that clarifying question. And then type 1 diabetes is a little bit different, so much less prevalent. Again, it's kind of the leftover 5 to 10% of folks with diabetes. This is an autoimmune disease. So people with type 1 diabetes, their immune system attacks those insulin producing cells in the pancreas so that eventually, most often, they have an absolute deficiency of insulin. So people with type 1 diabetes, whereas type 2 diabetes is more lifestyle and weight-based, type 1, it's an autoimmune disease. And people with type 1 diabetes are at higher risk for other autoimmune disorders in addition. So type 1 also has a genetic component. So people, if they have type 1 diabetes, their children are at higher risk, but there's also thought to be some environmental factors here as well. So it's thought that maybe somebody has a genetic predisposition to type 1 diabetes, and then maybe exposure to a certain kind of virus or other factor in their environment kind of triggers their immune system to attack the pancreas and develop type 1 diabetes. So in contrast to type 2 diabetes, where we can see people on a lot of different medications, and usually they start out with oral medications or pills, people with type 1 diabetes, they need insulin injections or use of insulin through insulin pumps to manage their blood sugar. And really, regardless of what type of diabetes someone has, whether it's type 1 or type 2, it's very important that we be thinking about really managing their blood sugars very well and other cardiovascular risk factors like their blood pressure or their cholesterol, because largely what we're worried about in these folks are diabetes complications like heart disease, heart attacks, strokes, as well as other complications like kidney disease, eye disease, and neuropathies in their nerves. So that's kind of a big picture on type 1 and type 2. And you also mentioned gestational diabetes, which is a form of diabetes that tends to develop in the second or third trimester of pregnancy. And so we have to manage blood glucose during that time, and often it will resolve postpartum after they deliver the baby. But those women who had gestational diabetes, we know down the line are at higher risk for developing type 2 diabetes later.
Thank you, Dr. Neumiller. And a follow-up question to that is, if someone is diagnosed with diabetes, does it necessarily mean that they must take medication for it?
Yeah, it's a really good question. And so if we looked at what like the guidelines from the American Diabetes Association and other organizations say, if somebody meets diagnostic criteria for, say, type 2 diabetes, the recommendations say we should intensify lifestyle interventions. So eating healthy, engaging in physical activity, and that we should start an oral medication called Metformin, which is our first-line agent. Now, this becomes a bit of a discussion between the provider and the patient, because some people would rather maybe intensify lifestyle and see if they can do without the medication. So it's kind of two sides to that question. There's what the guidelines say, which is start metformin, but some people, they just want a little bit more time to maybe change their lifestyle, eat better, engage in more physical activity to see if they can manage it that way. And some people do okay and can do that. The main thing is just not waiting too long before their blood sugar loses control. And I don't know, Dr. Newsome, what your thoughts or experience are on that as well.
Yeah. So I'm also really glad to get to be here and share some information about diabetes with our community members. I work in a diabetes clinic at the VA, and it really kind of depends on the patient as to how motivated they are and how confident they are that they'll be able to make those lifestyle changes and how ready they are. For some patients who maybe have been living a really busy lifestyle, lots of stress going on, and maybe haven't been paying as much attention to their health as some other aspects of their life, getting the diagnosis of diabetes can be a real wake-up call to reevaluate kind of their priorities and maybe their lifestyle, and might be kind of that extra push that they need to get them on a healthier path. So it kind of depends on the patient as to when we'll start, if we start things right away at diagnosis.
Thank you both for that overview. The next question goes to Dr. Newsome, and we see an increase in diabetes rates over the years. By one estimate, less than 1% of Americans in the US had diabetes in 1958. Now that number stands somewhere at 1 in 10 people in the US are living with diabetes. What are some of the causes behind this, and what are the strategies that people can take to prevent diabetes?
Great. Thanks for the question, Con. It's a great question. So the increase in diabetes has been seen more so in type 2 diabetes, which again is the one that's more lifestyle related. There is a genetic component for it, but it's also more strongly affected by lifestyle factors. And so the increase in type 2 diabetes is very much related to the change in our lifestyle. Compared to 50 years ago, we're much more sedentary now. Many of us have jobs where we're not active. We're sitting at a desk, we're in the same place. So, and also our diets have changed too. We have much fewer healthy foods in our diet and less healthy foods. So the good news is, though, there are definitely some steps you can take related to lifestyle changes to reduce your risk of getting type 2 diabetes. And these aren't just theoretical risks. There have been studies looking at patients who had pre-diabetes, which is when you start to have impaired blood sugar management, your body starts to have some dysregulation, but it's not quite to the threshold that we determine it as a diagnosis of diabetes. So they've looked at these patients who, were starting to show some early signs of diabetes, and they enrolled them in these kind of intensive lifestyle changes. And they found that it really did reduce the risk of developing diabetes significantly. And the specific interventions that are recommended to reduce diabetes in terms of activity is 150 minutes a week of activity that would be the equivalent of walking briskly. So don't have to work out super hard, but just enough to get your heart rate up, to get it moving, and that can have really good benefits. And like Dr. Neumiller said, what insulin does is it lets the glucose get into our muscles where we can use it for energy. So the more muscles you're using, the more glucose you're going to use up, and then that will, by a result, cause lower blood sugars. So activity is definitely a good component. And then the other one is diet. So the American Diabetes Association and other organizations, they don't recommend a specific diet. It's not like the Keto Diet or the Atkins diet. There's no specific diet that's recommended. It just recommends, a diet with an emphasis on those healthy foods. So on whole grains and legumes and nuts and vegetables and fruits, and cutting out the refined sugars and the processed foods, which is what most of us know, but I think implementing it can be hard. So in my clinic, I talk a lot with my patients about what specifically their diet looks like and what specific changes they might be interested in making, to get really specific about what changes might be achievable for them. So, and it's not everything at once, it's slow steps. So you really can make these interventions and changes and help reduce the risk of diabetes. And one more thing that can help is weight loss. And it doesn't have to be 100 pounds. They've shown that just a 5 to 7% reduction in weight can significantly reduce the risk of diabetes. So if you weigh 200 pounds, that's just 10 pounds, 10 or 15 pounds. If you lost that, that would have a significant impact on reducing your risk of developing diabetes.
Thank you, Dr. Newsome. That's really interesting. We actually have a few questions from our viewers. The first question is, when there is a change in metformin exposure, whether it be change in pharmacotherapy or due to drug interactions, how long will it take for these changes to be reflected on a blood glucose test?
So in terms of, so I think the question is really how long before you see changes in the blood sugar, when following up with people on metformin. I think, important thing with metformin, and it is a very good medication, first line recommended by the American Diabetes Association. It does take us a little bit of time to get to our maximum dose of metformin, because metformin has a lot of GI type side effects associated with it. So generally we start with lower doses and titrate it up over several weeks. So there is a little bit of lag just getting up to our target dose of metformin. And then it may take several weeks before you see appreciable changes in the blood glucose. Of course, the measure we're often looking at to look at overall blood glucose control is a measurement called the hemoglobin A1C, which is taken about every 3 months, and you're basically looking at how much sugar is sticking to people's red blood cells is essentially what this measurement is. And red blood cells have a turnover of about 3 months. So when you measure this every 3 months, it gives us kind of a look at how their blood glucose control has been over time. So generally when we start metformin, we start it, we titrate it appropriately, and typically we'll be checking that A1C 3 months later, and hopefully you might see some changes there. The one caveat to metformin, though, Dr. Newsome talked a little bit about pre-diabetes, and I know we've discussed, do we start that in everybody at the time of diagnosis? There are people with pre-diabetes who use metformin to try and help prevent their conversion from pre-diabetes to diabetes. So some of what you're going to see, like on those finger stick blood glucoses, is going to depend where somebody's starting. If they're, kind of borderline diabetes or pre-diabetes, you may not see huge differences in the blood sugars, but in somebody with, actually diagnosed diabetes, you should be seeing some change within 3 months. Dr. Newsome, what's your experience in the clinic?
Yeah, I kind of see something similar. It's really important for side effect reasons to start at the lower dose metformin and go up. And I see results, definitely within a few weeks. I kind of see the benefit and the change in patients' metformin in their blood sugars after their metformin therapy. So, yeah.
Thank you both. And we have another question, which is, how much is type 2 diabetes dependent on genetic factors versus lifestyle? If you could assign a percentage, for example. I know we were going to get to this later in our discussion, so I'll let either of you take this question.
Yeah, I'm happy to start. And I don't have a percentage. I'm not sure there's really a percentage out there to be found. And it's hard to tease the two out, particularly in type 2 diabetes. So we talked about that genetic component, and then there's the lifestyle and environment. And if you think about people maybe who have diabetes in their family, they may all have learned lifestyle behaviors. They probably all eat similar diets. So it is hard to tease out how much of that is truly genetic and how much of that is learned lifestyle kind of within that family unit. But, So I really couldn't assign a percentage one way or the other than to say you really have to hone in on those lifestyle factors because I mean, you can't change your genetics, but you can certainly change how active you are and your eating habits. Dr. Newsome, additional thoughts?
Yeah, it's kind of along very similar lines. I've never seen or heard of a specific percentage. And yeah, unfortunately, we can't change our genes, but you still do have control over the lifestyle aspects. So even if you do, have people with diabetes in your family, you may be at increased risk, but you can still take action to reduce your risk.
Thank you both. And we have another question I'm not sure if you have the answer to. How is the monopolization of insulin production in the US affecting your patients and your work?
So this is a big issue, and I'm glad someone brought attention to it. Insulin prices have increased in the United States drastically, and I work in the VA system, so we're kind of separated, kind of isolated from some of those price concerns my patients are, but it's a concern. It's very unfortunate, especially for people with type 1 diabetes. They must have insulin. Their body doesn't make insulin, so they're reliant on insulin. And so I know there's some states who have taken measures to put price caps on insulin. They can only be charged so much per month for insulin, but that's only a handful of states. So I know this is still a pressing concern for quite a few people with diabetes, a good portion who are taking insulin. Dr. Neumiller, what have you seen?
Yeah, totally agree. And, this has been something that's been high on the list of lobbying activities from major health organizations like American Diabetes Association and others. That there have been steps taken that have helped to a degree. So now we have some quote unquote follow on or biosimilar insulins that are on the market. The price hasn't dropped as much as maybe people would have anticipated with some of that, but it has lowered some of the prices. Some of the manufacturers are now offering non-branded options of their insulins, which helps a little bit. But it's a huge barrier, when people have to choose between all their other bills and buying their insulin, which often is necessary, as Dr. Newsome said, particularly for people with type 1 diabetes. Now, there are more affordable options, but like Walmart has $25 vials, but they're not the fancy insulins with the bells and whistles. So there are options out there, but it's still a huge barrier on the cost side for sure.
For people who don't have background on this, what has been the price increase on insulin in the last year, or can you give us some more background on this?
Do you want to take that, Dr. Newsome?
I think I'll let you start.
Sure. Yeah. And it hasn't, the last year or so, maybe not huge changes, but certainly over the last several decades, the cost of insulin has gone up substantially. Some of the data, if you look at over the last several decades, over 100% increase in insulin costs. I mean, from products that have been on the market, for that period of time. So one of the barriers here is that there hasn't been a real nice pathway for generics of insulin as there are with non-biologic drugs. So being a biologic agent, insulin, there's been some barriers there of getting some more affordable products on the market. And as was mentioned, we only have so many manufacturers, and it's certainly not just the drug companies either. There's the PBMs and a variety of other players in here that affect the cost on these. But it has increased substantially, certainly in the last couple of decades. And I think, over the last 5 years, there's been a lot of attention on maybe intervening and seeing what can be done as a larger healthcare system in the United States to lower costs.
Thank you, Dr. Neumiller, for the insight. That's very interesting. So one of the other questions that Dr. Newsome had touched upon is we've seen popular diets being discussed amongst healthcare providers as a possible solution to reverse diabetes. What is your take on intermittent fasting and diets in general in terms of treating or preventing diabetes?
Yeah, thanks. And again, Dr. Newsome did touch on this very nicely in terms of, the importance of diet and good nutrition on diabetes prevention as well as diabetes management. And when, the previous question about when do we start medications, I mentioned that really all of the major organizations really include nutrition and dietary counseling is really a cornerstone of diabetes management. It needs to be there. Certainly as pharmacists, we focus a fair amount on the medication piece, but we really have to investigate their nutritional intake and the like. And as Dr. Newsome said, there really isn't one size fits all dietary approach to people with diabetes. It has to be what works for them. They have to, we all gain some pleasure from eating, so we can't just take all that away from people. So we have to really look at their personal priorities and what they want to do. So medical nutrition therapy is often talked about as really a cornerstone of diabetes management. Intermittent fasting has been in the news a lot lately. It's definitely one of these diets that is more popular as of recently. Looking in the literature on intermittent fasting, there's quite a bit of variability in how it's described and what people are talking about when they say intermittent fasting. It can be anything from restricting food intake for 12 to 20 hours a day. It could be alternate day fasting, or maybe even real strict caloric restriction for multiple days on end. And so it's a little bit different in the data. When you're looking at some of the research that's been put out, often you're looking at different intermittent fasting strategies, if you will. So it's kind of hard to really look at these. I think one thing is clear, though, that we've hit on many times already is that weight loss and really managing weight is very important. And so if people can engage in an intermittent fasting eating program and it helps them lose weight, that's going to help them if they have type 2 diabetes. Now, there are some things I think we need to consider, particularly on the pharmacy side. So if people are on insulin or if they're on other medications like we call insulin secretagogues like sulfonylureas and others that can actually precipitate low blood sugars or hypoglycemia, we have to be really strategic in how people are adjusting their medications or engaging in intermittent fasting so that they don't cause harm and low blood sugar with some of these medications. So I'm always encouraging people, it's very important they talk to their healthcare team, whether it be their pharmacist or their physician, really talk to them about these type of eating strategies before they just kind of jump on the bandwagon to make sure they're staying safe. I personally, my approach, I never discourage people from any lifestyle or dietary changes that are interesting to them, because if that motivates them to lose weight, it's going to help with their diabetes. But I want that open communication to talk about some of the potential pitfalls and other things we need to consider with that. So weight loss is going to help there, certainly, but communication's huge. Dr. Newsome, have you had anybody engage in one of these intermittent fasting programs?
I had one patient who was real jazzed about intermittent fasting. And so I had talked with him about it and got him set up with a nutrition clinic through the VA. And he ended up not actually being able to really commit to intermittent fasting. And another patient, similar situation with the keto diet, where once they really got into it, realized it wasn't actually going to work for them in their lifestyle. So I haven't had any patients really who have been successful in really committing to those two diets specifically. And I'll just reiterate, what you said about how important communication is with a provider if someone with diabetes is planning to change their lifestyle in a significant way. just for safety, to make sure they're not going to have any low blood sugars when they, make changes to their lifestyle.
And one thing I would add, the science though is really interesting, and there's a lot of work looking into intermittent fasting in type 2 diabetes. And if I talked about how the pancreas and those insulin producing cells are having to work really hard in people with type 2 diabetes. There's some work looking into if they do have these intermittent fasting diets during those fasting phases, that potentially is taking a little bit of pressure off the pancreas and its need to constantly be producing insulin, and maybe can be beneficial in the long term in these people. But you brought up the keto diet as well, and that's another one that we hear a lot about. And low carb diets, very low carb diets, keto diets. These are other diets that a lot of people with diabetes hear about and want to try. Again, same types of things we need to be thinking about, making sure we're watching the blood sugar, particularly if these are people on insulin or other agents that can contribute to hypoglycemia, making sure they understand how to recognize hypoglycemia. They're checking their blood sugar more frequently. Really just erring on the side of caution if they do want to go this route, but very good research and data to show that these low carb diets can be very helpful, helping with blood sugar reduction, weight reduction. But if people are doing some of these keto diets, we also have to be thinking about fat intake and making sure we're talking to people again about their diet, making sure they're not getting too many saturated fats and increasing their cardiovascular risk as well. So Dr. Newsome mentioned about referral in her clinic. I'm a diabetes educator. I talk to people a lot about their diet, but I'm never shy or scared to refer to our colleagues who really specialize in this and who can really help people on a day-to-day basis fine tune their diet and do this correctly.
Yeah, and I'm not a dietitian, I'm a pharmacist, but I have at pretty much every visit I have with my patients with diabetes, I ask them about changes to their diet and how that's going, because it really does have a significant impact on their blood sugars. And patients, they'll perform these self-monitoring blood sugars and be able to check their blood sugar at a certain point in time, and they'll bring in those readings to me and I'll review them, and I'll find, some highs and some lows and talk with patients about, what happened around that. Did you eat less? Is that why you had a low blood sugar? Did you have extra activity that you weren't anticipating you were going to have to participate in? To really, or, if they have a really high blood sugar, did you have a real good dinner the night before? And, they're like Dr. Neumiller said, food's an enjoyable part of life. And we all get, some treats now and then. But, just kind of helping them identify, what the effects of different activities on their blood sugar are can be really, really empowering for the patients, as well as, help me make sure that I'm educating them appropriately and they're being safe with what they're doing.
It's a little bit of a tangent, but I'm curious, Dr. Newsome, continuous glucose monitoring, we can get so much information from that. And, as you talk about people learning about their diet and physical activity and what their medications are doing, do you use much of that in your clinic to kind of highlight some of these impacts on blood sugar?
Yeah, so continuous glucose monitor, it's something that it's worn on the patient, usually on their arm or on their abdomen or some other places. And it basically checks their blood sugar, every few minutes. It's checking their blood sugar so they can really see what their blood sugar was at every moment in the day. And, before that, or for people who don't have those continuous glucose monitors, they're, poking their finger, going through probably a 3 to 5 minute kind of procedure every time they have to check their blood sugar. They want to check their blood sugar. So continuous glucose monitors are much more convenient for patients. They, put them on and then it stays on them for about 2 weeks or different times depending on the device. But, it's there and it is so convenient for patients. So I do have a couple patients in my clinic who do have CGMs, or continuous glucose monitors, and they love them. And it's also, not only are the continuous glucose monitors more easy for patients, they're kind of more patient friendly, but they also actually have been proven to improve glucose management. People do better when they're have these continuous glucose monitors because they're getting constant feedback about their choices. So that's been neat to work with those patients, and they're really motivated patients. The two I have on continuous glucose monitors, and they get so jazzed about, being able to show me their trends and kind of when things are going well. And so it's been a real enjoyable. What about you, Dr. Neumiller? You have any experience with continuous glucose monitors or other benefits to add?
No, I think you really touched on them, but they're just incredible tools where people get that visual feedback, and from a safety standpoint, if people are on these, we can set alarms and threshold alarms so they can address blood sugars that are falling and putting them at risk for hypoglycemia before they actually have a low blood sugar. So incredible technology, and certainly, as you said, they're much more available for even people with type 2 diabetes now, where historically it tended to be more people with type 1 diabetes. So an incredible tool, and certainly something pharmacists can play an important role in really educating people about use and glucose trend management and otherwise.
Thank you both for sharing your insight just from a clinical perspective and also personal experience. Well, we can't not have a conversation without mentioning COVID-19. Dr. Neumiller, I know you've been working with the American Diabetes Association on several things, one of them being guidance for providers for individuals impacted with COVID-19. Can you tell us why people living with diabetes are more susceptible to COVID-19, and describe the resources that your team at the American Diabetes Association have developed for providers?
Well, thank you. This has been really an interesting thing to be involved with. The American Diabetes Association, shortly after the pandemic really escalated in the US, developed this website really with the hopes of providing healthcare providers with the most up-to-date information and resources available to them. I'll talk a little bit about what some of that looks like. But it's interesting, people with diabetes who have at least poorly controlled diabetes, we think about them as having increased risk for infections and otherwise in general. The verdict is a bit out related to COVID-19 and diabetes. Some of there's a lot of work looking at this, but right now it's somewhat unknown as to whether people with diabetes truly have an increased risk of contracting COVID-19 versus people without diabetes. But what we do know is people with diabetes, whether it be type 1 or type 2, but particularly type 2, because obesity and other comorbidities play into this as well. If they do contract COVID-19, they're at much higher risk for negative outcomes. And with this being one of the major diseases that increases COVID-19 risks. So we know that if people with diabetes develop COVID, they have more complications from COVID-19. They're more likely to have to be hospitalized to manage their COVID-19, more likely to have to be on mechanical respiration if they're hospitalized, and there's higher mortality as well. And we know that it tends to be in people with diabetes who have less optimal blood glucose control. There were some studies that came out several months ago out of China, actually, in Wuhan, where some of the outbreak really started, showing that people with diabetes, when they were admitted to the hospital, if they had, say, a hemoglobin A1C, which is that average of glucose control over 8%, those people had much worse outcomes than people who had a lower A1C when they came into the hospital. It's very important that people really control their blood sugar well during the COVID-19 pandemic in case they do develop it, so that they have the best outcomes possible. So going back to the ADA website, they did develop this website, and over time, basically weekly, and they've slowed down a little bit now, but initially, twice a week or weekly webinars on various topics to inform healthcare providers working in the diabetes space about various considerations in diabetes management. I was more involved on the medication consideration side, not only thinking about glucose management when people become ill, but also obtaining 3 months worth of supplies. So when in case people have to isolate or the like, talking to people about monitoring their blood sugar, how to get medications from their pharmacy while minimizing exposure. So these type of issues came up. There was also topics related to best practices in hospital care. So certainly hospitals were overflowing with people with COVID-19. So looking at resources on how best to manage these people, but also looking at innovative ways to decrease exposure to healthcare providers in that setting as well. And if there is a good thing to come out of diabetes management and COVID-19, I think it's going to be everything that's been learned about continuous glucose monitoring that Dr. Newsome and I talked a little bit about already. Some of these hospitals started to utilize CGM in the inpatient setting, where they would have these monitors basically taped to the outside of their hospital room door so that the nursing staff and other hospital staff didn't have to go into the room as frequently and expose themselves to virus and getting infected potentially. And so this is really advanced use of these types of remote monitoring technologies in the inpatient setting. So certainly that was part of it. And then telehealth, there's really been a need to help people manage their diabetes in their own home remotely. So really talking about some of the lessons learned about how to tell people how to use their new medications. If they're getting a new injectable, it's a little more difficult to teach them how to use a device over Zoom or Skype or just verbally over the phone. So really building a suite of tools and resources to kind of help other providers in the community work through these types of challenges.
And I'm curious for a question for both of you. We're seeing all types of supply chain issues when it comes to anything from gym supplies to appliances. Are you guys seeing any supply chain issues with things that are used to treat diabetes?
So we haven't had, at least at my VA and kind of what I've seen from my patients, is we haven't had any shortages of medications due to COVID-19. There was a recall on a lot or a group of Metformin tablets that were manufactured. And so those got recalled. And so because of that, Metformin has not been on shortage. We've still been able to get it for all of our patients that need it. But that's one medication that we're kind of watching to make sure we don't get a shortage of it. But I haven't seen anything related from COVID causing medication shortages. What about you, Dr. Neumiller?
Yeah, and I haven't either. I'm not aware of any insulin shortages or supply shortages. I haven't heard of anything, and I certainly haven't worked with any patients that had issues with access. It's really more kind of your typical payment type things that come up for medication access versus it being stocked in the pharmacy.
Interesting. So Dr. Newsome, I know that you work at the VA Medical Center here in Spokane. Can you share some of the questions and concerns that you get from patients living with diabetes during this pandemic, and how do you address them?
Yeah, sure. So I think what most of my patients with diabetes so I've been doing only virtual visits, telephone and video calls since March. I haven't seen any of my patients in clinic for quite a while. So I've been having mostly phone conversations with them. And when I talk with them, I notice they're having concerns that are very similar to the rest of us. They're worried about their health. They're worried about, their loved ones, their safety. So I haven't had too many patients with questions specific to their diabetes management. It's more kind of been more general kind of COVID questions and concerns. I'm glad at the VA we have a really robust mail out program for our pharmacy and our medications. So most of my patients are already enrolled with that. And but I did have some veterans who just really liked to come to the VA mostly for social hour. And so I had to talk with them about, the benefits of now using the mail order and, staying home as much as possible and, reducing the risk of acquiring the virus, COVID-19 virus, and any virus. I guess flu season's coming up too. So be sure to get your flu shot if you haven't. So yeah, mostly similar concerns to others. I had one patient who was doing a lot of mall walking. That was his preferred form of exercise. So, I had to work with him to see what other options, he could maybe pursue that would be a little safer for him during the pandemic. So.
Thank you, Dr. Newsome. And now I know both of you teach a class together on diabetes. What is the number one question that you get from your students and how do you address them?
You want to take that first, Dr. Newsome?
Sure. Yeah, so it has been a really fun course to teach. I really enjoyed teaching with Dr. Neumiller. We had a great group of students in it. And I think the most common question that we would get, well, I guess first let me explain a little bit more about our course. So it was mostly case-based. So we would give the students a case of a person with diabetes, and sometimes they were real patients from my clinic. And so we'd present them with this case and, talk through options. And a lot of times, with diabetes, especially type 2 diabetes, there's a lot of different medications that work in a lot of different ways. And so it may be that there's more than one medication that may be really beneficial for a patient. And I think the students, they really wanted a black and white answer. They wanted one medication that would be the best for that patient. And I think that was a really good learning activity for them to see that sometimes there's multiple good options for a patient. And, it may be that, I can't tell you what's right for that person. We have to kind of have them there, maybe explain the two options to them and see what they think would work better in their lifestyle based on, the route of administration, a tablet versus an injection, the frequency, how often they'd have to take it, what the side effects could be, what beneficial side effects they have. We have, at least 2 classes of medications that are associated with some significant weight loss. So just it kind of comes down to patient-specific factors. And sometimes if we didn't give the students enough to drive them directly to one answer, they kind of struggled with that gray area. But I think it was really good for them. And in the end, I think they got some good real world experience on that. What about you, Dr. Neumiller? What do you remember?
Yeah, I think so, when I'm teaching in our therapeutics courses here at WSU, where we get kind of the basics on diabetes, a big question I get is just how do people with type 1 diabetes kind of manage everything they need to do? And so I'm a person with type 1 diabetes, so I don't get to spend as much time talking about that in the normal classroom setting. So this elective really gave Dr. Newsome and I the opportunity to really expose those people in our advanced elective to some of these considerations. So Dr. Newsome really led the charge on a empathy exercise where we actually sent people home with blood glucose monitors and asked them to check their blood sugar throughout the day and log what they're eating and write down how many carbohydrates they intake. And it was really eye-opening for them to really say, gosh, this does take a lot of energy. And I think a lot of people appreciated it. Along with that, the other one that I think was kind of fun that we integrated into the course was related to carbohydrate counting, because often I think when we're working with people with type 1 diabetes and their blood sugars are fluctuating, it's easy to kind of say, gosh, they're doing a lousy job counting carbs and calculating their insulin doses. So what we did in this class is we had them come in on one of the class days, and we had a platter of food covered at the front of the class, and actual food. Had them all come up, send a representative up to take a picture, unveiled it, and they had to go back and calculate how many carbs were in a plate of food. And it was it was entertaining because I think we had a tenfold difference from kind of the lowest to highest. And we said, well, now calculate the insulin dose, and the insulin doses were just astronomically apart on the low and high end. But then we did have a couple groups that were just right on the money with the carb count and the amount of insulin to be taken. But I think these type of activities allow us to really instill some of that empathy and kind of real life considerations for the students.
I'm just curious what was on that platter of food.
Yeah, it wasn't a low carb diet example. I think we had what was it? I think we had like a hot dog and it was like a barbecue type of platter with a hot dog and potato salad and baked beans and things like that. But the biggest challenge was it's all kind of just splattered out on this plate, and the students had to guess actually how much food was there because they didn't have a label or a quantity there to look at, which is often what people have to do out in the community when they figure out how much insulin they need to take. So it was kind of fun.
Very interesting. And just one last quick question. As we are the College of Pharmacy and Pharmaceutical Scientists, what role do pharmacists play in helping patients manage diabetes?
Yeah, so I can start off on this one. So I have a pretty advanced role at the VA. So I'm a pharmacist, but I actually have prescriptive authority to adjust medications for patients, stop medications, start medications. And I think that's a great position for pharmacists because we are the medication experts on the healthcare team. So, pharmacists should be involved in picking the medications for those patients. So I feel like that's a great role for pharmacists. We know the medications, forwards and backwards. We know the side effects. We know the differences between the medications in the class, and we have all those details. So I definitely think pharmacists should be involved in the medication selection. But then, the sky's the limit. Like I said, I talk to my patients about diet and physical activity at most visits I have with them. So, I mean, we're well trained to really help kind of all aspects of diabetes management.
Yeah, definitely agree with Dr. Newsome, and she's certainly an amazing example of a pharmacist really playing a huge role in diabetes management at her practice. And really any setting, pharmacists can be very impactful on overall diabetes care. We've talked about diabetes education. I'm a certified diabetes education and care specialist. So providing diabetes education to people, whether that be related to their medications, which of course pharmacists do a really good job at, but also pulling in all those other considerations about lifestyle and the like. Certainly a lot that can be done in the community setting. We talked a little bit about continuous glucose monitors. Now we have those available over the counter at the pharmacy. People will probably struggle a little bit if they just pick that up and take it home and try and figure it all out. So pharmacists can just play a huge role in educating people on how to maximize the benefit of these, not only their medications, but also all of these monitoring devices and otherwise. And I will say, I've been fortunate to be a volunteer for the American Diabetes Association and some other organizations. And I will just say that these organizations, they definitely value pharmacists as a member of the care team. And so I think if anybody listening is interested in diabetes and wants to get involved, you're going to find a lot of opportunities to do so.
So we are rounding the top of the hour, and I want to thank you both so much for sharing your insight. You have a wealth of knowledge about diabetes, and it's been a really interesting conversation. Before we go, we have a quick message from Evan Barton, our recruitment and outreach specialist at the school. Evan, take it away.
Thanks, Connie. I just wanted to remind everyone that we have an upcoming virtual fair on September 30th, where prospective students can ask questions and chat with our current students, faculty, and staff. And I also wanted to remind everyone that our application deadline is January 4th, 2021. But we are encouraging applicants to submit their applications early, as we have interviews coming up in November and December. And if any prospective students or advisors that are on this video today have any questions, they can always reach out to us at our admissions email that I'm going to include in the chat in just a minute.
Thank you all for joining our first ever Health Chats. If you know of anyone who might be interested in future Health Chats, we encourage you to forward on our future invitations. You can catch us on YouTube monthly. Our October Health Chats is guaranteed to be a hot topic. We will be having Dr. Kim McKiernan and Dr. Nicole Perea on Wednesday, October 28th, to talk about vaccines, flu season, and implications for the COVID-19 vaccine. Look for our invite in the coming weeks. And until then, we are wishing you all good health. Thank you.
Thank you.